Good afternoon to one and all. Today I'll be presenting to you an emerging infectious disease of the cornea, microsporidial keratitis. Despite its clinical significance, it is often misdiagnosed and treated as adenoviral keratitis, leading to suboptimal outcome for the patient. So we aim to explore the clinical features, diagnostic methods, that is simple diagnostic methods possible in our OPD, and we assess the treatment outcome along with clinical distinction from adenoviral keratoconjunctivitis. So we conducted a retrospective analysis in our tertiary center on patients presenting with symptoms of keratoconjunctivitis from 2020 for the next 3 years, and EMR of the patients who were diagnosed earlier with microsporidial keratitis or adenoviral disease were reviewed. The clinical characteristics and all other duration of symptoms and findings were also documented. We also utilized the corneal scrapings and anterior segment OCT to confirm the diagnosis. Treatment outcome and visual treatment modalities and visual outcomes were also assessed. So among the total 58 patients who presented with keratoconjunctivitis, we had 22 patients who had diagnosed as microsporidiosis as primary diagnosis. There were 10 patients who were treated elsewhere and misdiagnosed as adenoviral disease who presented to our center, and we had documented 26 adenoviral cases in our center. So the peak prevalence of the disease was noticed in rainy season, especially in between the months of June to August. And patients with microsporidiosis also had longer duration of symptoms compared to its adenoviral counterpart. So microsporidiosis patients, they typically had a unilateral ocular involvement presenting as a stuck-on appearance on the cornea due to the presence of spores, and we can see the slit lamp photograph showing the same. So among all the patients, we had 31 patients whose visual acuity was unaffected. Earlier patients were treated with voriconazole, but later, after revised protocol, our patients were given only a symptomatic treatment, which showed favorable outcome with resolution of symptoms and improved visual acuity, thereby bypassing the use of steroids and its harmful side effects. Despite its prevalence, microsporidiosis is being underreported, probably due to the misdiagnosis. The spores of microsporidia can be easily dislodged with a bud, which can be used as a simple OP-based diagnostic method, distinguishing it from adenoviral disease. So we can see the anterior segment OCT of the microsporidiosis patient, where we can see the superficial hyperreflectivity due to the presence of spores. Meanwhile, adenoviral keratitis patients that present with bilateral diffuse punctal epithelial keratitis, subepithelial infiltrate and anterior stromal opacities. Corneal epithelial debridement can be used as may help in decreasing the bulk of microsporidia, but no final outcome, there was no major difference. Even no specific drug treatment was for, there were many reports of specific drug treatment, but their effects remain controversial. So coming to conclusion, microsporidiosis has typical clinical appearance. Even though it often masquerades as adenoviral keratitis, we can, if there is any doubt, we can use corneal scrapings and anterior segment OCT to diagnose the disease. So increased awareness is necessary about the disease for optimal patient outcome. Thank you.
So the only diagnostic modality that you used was ASOCT, is it? To differentiate between the adenoviral and the microsporidiosis?
Yes, sir. Along with the clinical based technique, we use the cotton bud.
Clinical suspicion as well as ASOCT.
Yes, sir.
Now the reason why I'm asking this question is because, see, the thing is, you in the ASOCT picture that you showed more of this subepithelial reflectivity, right?
In
adenoviral.
Yeah.
In the adenoviral ASOCT, you showed that. But the problem here is that particular ASOCT findings that you're seeing is towards the later part.
Okay.
Understood? So you can't use only that as your diagnosis. Did you stain any of these patients?
Yes, sir. Some of the samples were sent
So
for gram stain.
among them, how many were positive?
Actually, few of them were positive, but the sample size was not adequate in most of them because they asked for at least 3 slides were necessary.
Yeah. See, because both the diseases are self-limiting. Both are actually self-limiting. Okay. Only if the stroma is involved then becomes a different thing. But the epithelial variety of both or most of them are self-limiting, right? So how do you know which one is which?
In microsporidial, it is basically superficial hyperreflectivity.
Whereas here it may not be.
It may not be the case. Thanks.